to welcome you all to the second day of the 5-day-long international webinar on COVID-19, focusing on Kerala situation. Yesterday, we had an excellent discussion on the variants of COVID-19 virus, how the genomic study and big data analysis helps us in fighting COVID was discussed. Today, we are focusing on vaccines. Even though Government of India have given permission for 5 vaccines for emergency use, only 2 are widely used. As on today, 39.5 crore Indians have received 1 dose of vaccine and 11.2 crores of Indians have received 2 doses of vaccine. It's a huge number, but when you compare with the India's population of 136 crore, it is nothing. And the Kerala situation is also not very much different. But I am very happy to say that most of the healthcare workers in Kerala are vaccinated. And I am extremely happy again to say that great majority of the 100,000 students of Kerala University of Health Sciences, the health professional students, are vaccinated. And ours is the only university in the state of Kerala that is open and conducting classes and examinations. But we are following all the COVID protocols. No physical theory classes are permitted because of the danger of crowding, but practicals and clinical training are going on. Because of these precautions, none of our institutions had formed any COVID clusters. I'm very happy to say that, except one college. There, many students were celebrating the World Cup football in a same room without mask, and 26 of them got COVID. But all these 26 students had 2 doses of vaccine and none of them had any serious symptoms. Today, we are discussing how the vaccines are going to help us. Can we have multiple vaccines? And at what interval? And what are precautions we have to do? All these questions will be answered today. We hope Jennifer Hussain, an eminent virologist from the Institute of Human Virology at the University of Maryland, USA, will join. She was supposed to join. We expect that she may join any moment. And in advance, I thank her if she joins. Today's discussion will be moderated by Professor Indu PS, Professor of Community Medicine, Government Medical College, Thrissur. As you are aware, she is a very important member of the committee which advises Government of Kerala in tackling the COVID-19 situation in the state, and Kerala is doing well. Thank you, Indu, for being the moderator. Dr. Sina Nujum, Associate Professor of Community Medicine, Government Medical College, Kollam, will be elaborating on the COVID vaccination situation in India and the state of Kerala. Thank you, Sina, for being with us today. I welcome all the participants who are here. I welcome you all once again. Let us have a very good discussion and interaction so that we will get more ideas for collaboration and also to do research. That is our ultimate aim, to do research on various unanswered questions. COVID has given us a lot of issues and we have a lot of unanswered questions, and it is the business of the university to find answers, and this webinar is primarily intended to do that. Thank you all.
Thank you very much, sir. Actually, the first talk on today's topic was from an international speaker, Dr. Jennifer Hussain from the Maryland University. We hope she'll join us soon. As Mohan sir rightly said, we are in the midst of a pandemic and science is the star of the pandemic. The discovery of vaccines revolutionized the way countries managed the pandemic. This is very evident from several countries where the actual rates, even though the numbers have not come down, actually the numbers have gone up in several continents, including the Europe and the Americas of late, mainly driven by the Delta variant. We had a very elaborate discussion on the genomics of the SARS-CoV by eminent international and national speakers yesterday. Thanks to the Kerala University of Health Sciences for leading that academic event. And today, in continuation of what has been discussed yesterday, the Delta variant, which is actually driving the peaks, not only in Kerala, actually Kerala situation can be compared to many other countries, especially the UK and the USA. If you look at what has happened in UK over the past 6 months, in January, the UK had a huge surge with nearly 13 lakh cases, which was driven by Alpha. In July, again, another peak where nearly 10 lakh cases had happened. The death rate in the January, the Alpha-driven peak was more than 2%, 35,000, more than that, so many deaths. But last month, it was just 1,500 or so, 0.14%. And what has made the difference? Science has made the difference. And that's why science is a start. To be specific, in this context, vaccine. Of course, diagnostics is important, the therapeutic interventions, all other armamentarium science has provided us to contain or manage this pandemic are important, but vaccines have made the difference. Almost all the trials, starting from the mRNA vaccines, the vector vaccines, all those initial randomized control trials used the same vaccine as the first shot and the second shot, the prime and the boost. But of late, of course, the trials had been, we really have a large database from what's happening in the field, from real-time data among those who have been vaccinated. Basically, as prospective, cohorts, prospective cohort studies, and also the case control studies, the test negative case control studies. Those are the comparison of vaccines. But then beyond that, the trials that have used the heterologous vaccines, especially it's not only the immunogenicity question that has driven, testing 2 shots of vaccines, different vaccines as first dose and second dose. It was also the adverse events. As we know, what has happened in Europe, there was a big, hype and issue going on around the TTS, which was secondary to the Oxford AstraZeneca vaccine in many of the European countries. And then they thought of, having Pfizer as the mRNA vaccine as a second shot. That was not the only context where the heterologous vaccines were tried. Of course, the primary research question was the immunogenicity itself. We have results from 2 major studies, both randomized controlled trials from the Spain, the Combivac, and the UK, the Comcovi. We hope you will listen to more details, and both these are really promising studies. And of late, of course, several other studies are ongoing in USA. Even Johnson & Johnson as one of the combinations that's being tried in USA, and that's getting, of course, the vaccine is getting introduced in India as well. And we also have other studies going on in Germany, France, etc. Of late, the DCGI, the Drug Control General of India, has given sanction to Crescent Medical College, Vellore, to undertake a randomized controlled trial with Covaxin and Covishield, the 2 vaccines which are being given in India. But then actually day before yesterday, the ICMR has released the results. It's said to be peer reviewed. It's not a trial. It's just a report on the serendipitous use of, what has happened to those 18 patients in Uttar Pradesh who had received by error of a nurse second dose and first dose Covaxin and Covishield, right? The immunogenicity reportedly it's said to be published in a peer-reviewed journal. But that's the story in short of heterologous vaccines, 2 vaccines as 2 shots. The story of vaccines continue. Lots of questions arise in mixing vaccines, including what should be the 3rd dose. Will we require a 3rd dose at all? And the larger question of equity in vaccines. if vaccines could reduce the number of deaths to drastic levels, if vaccines can just convert the SARS coronavirus to induced COVID disease into something like a common cold, and people can continue to work, economy can move, schools can restart, what proportion of population has received it? 75% of the vaccines that has been distributed across the world has gone to 10 countries. Vaccine equity evolves as a larger issue, even within, it is actually more pertinent in countries like India and Kerala. Also, we know the situation. Definitely, Senior will give much more details on the situation, the challenges, and the opportunities in the context of vaccination in India and Kerala. So, Dr. Jennifer Hassan, has she joined? Let me just check whether she has joined.
I think she has not joined, but
Okay.
I could connect to Dr. Shyam, who organized everything, and Shyam said he is tracking her. So
Okay. Let her join, sir. Anyway, we have only 2 speakers for the day. We have enough time, and we expect a lot of questions also, because it's really pertinent. Today, actually, the positivity rate in Kerala has gone up to 15.9%. It was actually, plateauing off around 12%. Now, today it has gone to, it's nearing 16%. Anyway, there is a concern. I know the opening up happened a few days ago, and we are expecting. So, of course, vaccine is the talk of the town. Lots of issues at the science, at the practical issues, lots of practical issues to be discussed in the mixing context itself. Whether, because, whichever possible vaccines are available in a country, whether they can be given. Well, WHO has cautioned against individuals taking decisions. And of course, in science, since this is organized by the university, which deals with science and generating knowledge, like we have to talk based on the data, of course. That's also there. So, as Honorable VC mentioned, the scope of research in this area also is one of the issues that comes up during the webinar. Shall we move on to Senior's presentation? Dr. Senior is a young researcher. She is an alumnus of Government Medical College Trivandrum, both MD, MBBS, MPhil, and PhD. Her PhD was also in communicable disease research in the context of dengue. She also received a WHO fellowship in relation to her dengue research. Senior?
Hello, madam, can you hear me?
Yeah, we can hear you, Senior.
Shall I start, madam?
Yes, sure.
Thank you, Indu madam, for the nice introduction. I think I'll go without this. Thank you, Indu madam, for the nice introduction. Respected Vice Chancellor Mohanan sir, Raj Mohan sir.
Senior, Sanjeev says it's not loud enough. I can hear you. Raj Mohan sir, is the audio okay?
Indu is audio is
it's
not
okay.
very
It is
loud.
okay. It is okay. It is okay. Now.
But we can't hear.
Senior, please try.
Hello, hello.
Volume is not good enough. Maybe can you actually make some adjustments? Then?
Please keep the mic close to your lips, Senior. Yes,
hello?
that may be better.
Maybe you'll have to talk slightly louder.
Hello?
Yes, Senior, you may have to talk louder.
Am I audible now, sir?
Yes,
very
better.
well now.
Very clear, madam.
Okay. So thank you, Indu madam, for the nice introduction. Is it okay now? Shall I
Perfect.
proceed? Yes.
Perfect.
Respected Mohanan sir, our dear Vice Chancellor of Kerala University of Health Sciences, Raj Mohan sir, Suma madam, And I see a lot of eminent faculty of the Kerala University of Health Sciences among the audience. Respected all, I first of all take this opportunity to acknowledge and thank my dear teacher, Rajmohan sir, for giving me this opportunity to present before you. Good evening to all. Actually, we were expecting Dr. Jennifer's talk first, but unfortunately or fortunately, I have become the opening batsman or batswoman, I should say. I'll try to take you across through what is the scenario regarding COVID vaccination in India and Kerala, and also try to bring up some of the challenges which have come to my understanding with the limited knowledge that I have. And I'll open up those challenges with some of the way forward that I see before me for discussion, because there are a lot of eminent faculty and experienced researchers and teachers amongst us who can add more light on these areas. So with those few words, I think I will start sharing my slide. Slide is visible. Other
Yes,
slide.
yes.
Yes. Okay. So the topic for presentation is COVID-19 vaccination, the situation in India and Kerala, the challenges and way forward. So this is, as we know, the landscape of vaccine in India. I just put it because we were expecting an international speaker also. All of us know that the mainstay of COVID vaccination program in India are basically two vaccines. One is the Covishield. The Serum Institute of India makes Covishield under license from AstraZeneca, and nearly 90%, to be exact, around 88% of the administered vaccine in India today is Covishield. Following, we have Bharat Biotech, which makes the locally developed Covaxin. And we also had Sputnik V. Initially, around 3 million doses were given. And now we do have some of the hospitals in the private sector who purchase Sputnik from the manufacturer and deliver it. Otherwise, it is mostly Covishield and Covaxin that is being administered in India. Coming to the coverage of India, we know that the total population of India is around 139 crore or 1,394 million, of which one dose of COVID vaccine has been administered to 40 crore 19 lakhs 98,863 people, adults, which accounts for 29% coverage, and 2 doses has been given to 11 crore 37 lakhs 73,749 adults, which accounts to 8% coverage. So the total doses that has been administered in India till yesterday is 51 crore 45 lakhs 268, and this is available in the website. If we compare the COVID vaccination coverage from other countries, we have seen right now that India has given vaccines to 29% of the population, of which 8% is fully immunized. By fully immunized, we mean that they have taken the 2 doses of vaccine. But comparing with other countries, like we have many countries who have given full dose of vaccine or 2 doses of vaccine to about 50% of the population, like the United Arab Emirates, Uruguay, Chile, Spain, United Kingdom, Israel, France, Italy, Bahrain. So many countries have given 2 doses of vaccine to more than 50% of the population, whereas we have been able to give 2 doses of vaccine or fully immunized, we have still only 8% of the population. I have not put the global figures here. In fact, I was expecting the global figures to be said by somebody else, but around 30% of the global population have been vaccinated by at least 1 dose of vaccine, and nearly half of that, that is 15%, have received 2 doses of vaccine. This data is taken from the Our World in Data. In fact, they have a database that is there online, which we can look and we can have. We can actually download the Excel sheet and we can also analyze the data. And they are updating it daily. And this is another figure that is published in that site, and which shows the number of people that is vaccinated against COVID-19. What we should see is that in spite of 8% only being vaccinated in India, we are the leaders who have given the maximum number of doses to our population. And India has given 395.67 million doses till yesterday. And of which 113 million have received 2 doses of vaccine, and the rest to 82.67 million have received 1 dose of the vaccine. And close behind us is the United States. So we have, in fact, in terms of number of doses administered, overtaken the global leaders in economy, the United States, and even United Kingdom, Mexico, Germany, Brazil, etc., Italy, all of them in terms of numbers are behind us. So that this is again the same figure to tell us that in terms of number of doses as given in the country, we are the leaders. What about Kerala? We have, in fact, I have limited my slide and presentation to 20 minutes because we were thinking that we'll have an excellent talk by an international speaker. So I've just put on the major things on my slide. The vaccination, if we look in the Kerala context, we also started vaccinating just as when we started it in India on January 16, 2021. And the program is being run as per the operational guidelines of the Ministry of Health and Family Welfare, which is released on 28 December 2020. And all above the age of 45 years are targeted for vaccination. And in the age group of 18 to 45 years, we have prioritized it to give to those who have comorbidities, and that is considered, the age is considered 18 years or less than 45 years as on January 1st, 2022. And for those who are in the above 18 to 18 category, they have to upload their certificate of comorbidities in a Kerala site, which is also given. So the projected population of Kerala for 2021 is 3.5 crore. And taking that into consideration, the vaccinated, 1 dose has been received by 15 crore. It is 1.5 crore, 41 lakh.
Yeah.
Just 815, sorry, 154. Okay, so that is understood now. Suddenly I got messed up with the millions and crores. Okay, so that is the percentage of population vaccinated with 1 dose is 43%, and the percentage vaccinated with 2 doses is 18%. So if you would remember the Indian figures, we'd remember that the 1 dose of vaccine was available to 29%. We have 43% here. Around double, and then percentage with 2 doses for the India context, we said 8%, and here now it is 18%, which is 10% more. And we are vaccinating per day around 2 to 5 lakh population, and India we are vaccinating around 50 to 60 lakh population. There were days when we had given vaccination as high as 64 lakhs in India, and I think in Kerala also we have given 5 lakhs doses per day. That is very recently, and these figures are available in the dashboard of Kerala website. And this is again to show you the coverage that is across the districts of Kerala. And if you look here, you look at the grand total. Earlier we said that 1 dose of vaccine has been received by 43% of population, but if you look at the figure here, it is 54%. And the difference is because here they have considered the target population, that is those people above 18 years only. Whereas in the earlier figures, when we discussed the world figures, India figures, and Kerala figures from the Kerala government portal, the total population has been taken into consideration. Here it is above 18 years only, and that is why we have a figure that is higher than 40 to, that is around 54% of the eligible population above 18 years have been vaccinated with 1 dose, and 2 doses have been given to 22% of the eligible population. And if you look at the districts, we will see that Pathanamthitta leads with 33% of the eligible population having been covered with 2 doses of vaccine. And even if you look at the 1 dose vaccine, I think Wayanad with 1 dose vaccine as the highest figures, closely followed by Pathanamthitta. And if you look at this districts of Malappuram and Palakkad, as usual, even in the other immunization programs, we know that the coverage in Malappuram is less. And here also we see that with Malappuram has only 17% of the eligible population having received 2 doses of the vaccine. So this is one thing that we need to look into. Even within the state, there is a heterogeneity in the coverage, and not much, but disparity, but still there is some disparity in the coverage with vaccination. And this is a map that shows the coverage across the different states of India. And as we have seen previously that we have got 18% coverage in Kerala with 2 doses of vaccine. So we are slightly green. That is a green as far as the India is concerned, but that may not be a very a green picture if you consider the required coverage of vaccine. Then we have some other states also in the north and east that is having this more than 15% coverage. And so that is about, and this is with the 1 dose of vaccine. Here we have, this is a little earlier slide. So that is where we have 43% now with 1% of vaccine coverage in Kerala, but it is, the other figures are almost the same. So what is the way forward? What are the challenges with regard to coverage and the way forward? So I'm trying to putting across some of the things that have come across my limited understanding. So we actually do not know what is the estimate of coverage that is required. We say we are targeting to give vaccination to the entire population of adult population by the end of December 2021. That is what is being said. But what is the estimated coverage that would be required for us to halt the pandemic, or for us to bring down the transmission of COVID-19, or bring it to at least a stable level, as earlier Indu Madam was telling that it should become another common cold virus among the other coronaviruses. What is the coverage that would be required? Actually, we do not know that. So that is something that is up to us researchers and up to us the academicians to work on it, to model it, and to find out. Another challenge is that ensuring uninterrupted supply. We do know that in our state, and even in the news in the morning today, our health minister was telling that in the state, we are actually running short of vaccine. If we do not get vaccine from the government of India soon, we will run in for a shortage of vaccine. So how do you ensure the uninterrupted supply of vaccine? By scaling up the indigenous production? Do we have to think of import of vaccine? And here is another area where this potential of mix and match of vaccines will help us. Actually, in mix and match vaccines, we were hoping to hear from Jennifer. Probably we will hear her soon. Today, we will hear her soon. This mix and match of COVID-19 vaccine, especially important in Kerala context, because we do have a lot of migrants in our state. We have immunized some of them with Covaxin, and then they recognize that this Covaxin is not approved in the country where they are going to work. So then they're asking us whether we can take Covishield. This is one context in addition to countering the short supplies of the vaccine, where we need to have an idea or evidence on mix and match of vaccines. And this is another challenge for us. Then regarding the policy changes, we now know that there are evidence to show that once a person has become infected or has suffered from COVID-19 disease, if that particular person is given 1 shot of the vaccine, they mount up the immune response very well. In fact, a second dose of the vaccine may not raise the immunity beyond that which was given by 1 dose. There are evidences coming up to show that. And in fact, can we go in for a policy change so that we can save a few doses or at least some vaccines, doses of vaccines by administering one dose to those who are already infected? This is another question for discussion. And another is increasing the pace of vaccine so that we can get to the coverage. How can we increase the private sector participation? And then coverage evaluation studies. Of course, we do have the data being fed in the CoWIN and all what is the percentage immunized, we do get it from there. But then we know this CoWIN is a digital platform, and we know that how people are having trouble with getting registration and all those things. So even the most, the people who are most tech savvy are finding it difficult or have been finding it difficult to register in Kerala. So what would happen with the rest of India, the rural corners of India, where people are not so digitally advanced? So even when we say that we have covered 8% with 2 doses of vaccine, who are those people who have got the full dose of the vaccine? Have we left out, or is there a disparity there, or is there an inequity there? These things will come up only if we really take up coverage evaluation studies. And also we need to look into whether the marginalized population, like the tribals, like in Kerala particularly, we have a lot of migrant population. What is the coverage of vaccine among them? So these things and all we can understand only with proper coverage evaluation studies. Together with that, we can do process evaluations also in order to find out whether there are gaps in the process of delivery of the vaccine, how is the cold chain maintenance, how is the delivery, and all those things, because the efficacy need not really transform into effectiveness in the field. So we are talking about this, what is the coverage that is required to halt the pandemic? And we said that we need to build that model, or we need to work out that model for India and Kerala. So this is an example of a study which is published in the American Journal of Preventive Medicine, which says that different efficacy points, 60%, if you have a vaccine, where we are delivering a vaccine of 60% efficacy, the coverage should be 100%. And taking that R0, in fact, it's not R0. R0 will be the basic reproductive number at the beginning of the pandemic or the outbreak, which moves on to the RT, which is the reproductive number that varies over time. That also has to be considered. They have considered that also in the model. And they say that if you have a vaccine with only 60% coverage, 100% of them have to be vaccinated in order to bring a reduction in the peak for more than 99%.
Sinia, your audio has gone.
Okay. So till where did we...
No, sorry, it's my problem.
Okay.
You are very much audible. Sorry, my problem.
It's okay, sir. That was a break for all of us. In fact, somebody was sleeping, they would have woken up by now. Okay, so shall we continue? So we were talking about the modeling exercise that was done to find out what would be at different vaccine efficacy points, what would be the coverage. So if you have a vaccine of around 70% efficacy, in fact, the vaccine that we use here, the Covishield, has got 70.4% vaccine efficacy, and the Covaxin we say has 81% efficacy. That is what is said about Covaxin. Okay, so we look at that. Let us take it as around 70% vaccine efficacy, which is the lower side of it. We would need 75% coverage. Where are we now? This is their modeling exercise with an R of 2.5. In fact, we need to model it out here. But then even if we take this as true, we need to reach to 75% coverage. So we have only full coverage of 8%. So where are we? So likewise, they have said for 80% and for changes of R of 3.5, what is the coverage that is required? And they say that it's also true when the pandemic is going on and you have a transmission. That is where we are, and when we have a transmission around 5 to 30%. So we know that the seroprevalence study has come up with the ICMR, which says that the fourth round says that we have around 67% seroprevalence. Okay, so around that, which means that so much of the transmission is higher than that. So we need to model for that level of transmission, what would be the coverage of vaccine or the coverage or the immunity that would be required. So that was the first challenge and solution that we discussed. And the second is the scaling up of the vaccine production. The Serum Institute of India, according to the manufacturers, they have a capacity of 110 to 120 million doses per month they can produce. The Bharat Biotech International Limited has a capacity of 10 to 100 million doses per month. In fact, although they say that they have this much production, I think they're lagging behind in production, and some quality issues with some of the manufacturing units are also there. And with regard to Sputnik, we do not have so far being manufactured here, but there are plans to start local production in India. And their aim is to produce 300 million doses. That is not for a month, but for a year. And there is another the vaccine, that is the Novavax. We know that is a protein vaccine that is developed in US, and it is under the name of Covovax in India, that is being manufactured by the Serum Institute of India, but that has not got regulatory approval as yet. So we need to scale up this vaccine production, because in the later slides, we will come to know what is the number of doses that we might require for 1 month in order to achieve our target. The other thing is the vaccine import. So what should we think of vaccine import? What was the situation is Moderna vaccine has been granted emergency use authorization in June, but so far we have not received any, or they have not sent any vaccine to India. And Johnson & Johnson and Pfizer, they have not applied for emergency use authorization in India. So what is the problem here is that the foreign-made vaccines are facing legal hurdles because the manufacturers desire indemnity protection. That is, they do not want to have any claims that is being, the claims being ratified or being paid by them from the manufacturer's side. So, but the government of India, what is happening now with the Indian manufactured vaccines also, the indemnity claim that is being settled by the manufacturers. So because of this, there is a hurdle, and there are we need to take lessons from other countries, how they are managing it in terms of having in pooling of risk or some insurance mechanisms which can take care of this. And we should, in the near future, we should think of how we can import vaccines as well. That is what I think. And if somebody wants a better read on this, there is this article link that is given here, which you can go into to read more about it. And then we said that we need to think of mix and match of vaccines so that we can counter the vaccine shortages or short supply of vaccines, about which Indu Madam has talked in the beginning. But just to reinstate that, because we wanted to listen to mix and match studies. So DCGI has given approval to CMC Vellore to do a mix of Covishield and Covaxin, and that will to help us to counter shortages. And Covaxin is, that's the point what I wanted to mention. I said earlier also, some of the countries do not approve of this Covaxin, and we have several people who have taken Covaxin as their first dose. So this might help them. The phase 4, this is labeled as a phase 4 clinical trial, because both Covishield and Covaxin is already in use. The questions that we are trying to address is on safety, immunogenicity, and effectiveness against the variants. And in fact, as Madam said, we just got this accidentally, the ICMR study from UP, India. 18 individuals were inadvertently given the Covishield as the first dose and Covaxin as the second dose. And they compared the safety and immunogenicity of these 18 individuals with 40 individuals each. 40 individuals who are given both doses, homologous doses of prime booster with Covishield, and 40 individuals who have been given with the Covaxin. And the safety was found to be similar, And immunogenicity, what they found was, this is to our surprise, is superior for the heterologous combination. Immunogenicity was superior against alpha, beta, and delta variant.
May I interrupt, madam? Dr. Iqbal has joined.
Okay. Should I stop now?
No, no, please continue. Please continue.
Okay. So that is what we know about this study. So far, what we were telling about some of the challenges in meeting the coverage, we talked about the coverage. Sir, since sir is aware of all the coverages, I'm not repeating all those things, but we are talking about the challenges that we are coming across in terms of not having some studies which model on the estimated coverage that would be required to interrupt transmission. We have talked about how we could scale up the vaccine production in India indigenously, think about import of vaccines, and we had talked about the mix and match study that and its relevance for India and Kerala. Now, the another point that we said is the pace of vaccine administration. So this is again from that side which I mentioned earlier, which tells about the daily COVID-19 vaccine doses that is administered per 100 people. And if you look at this India, we are administering 0.41, that is less than 1 per 100 person per day. That is the pace at which we are administering. Okay, so this is the pace from the beginning of the vaccination. We started January 16, and we have actually picked on the pace. We have actually picked out on the pace, and in terms of million doses, the earlier figure was per 100 people, but this is the doses per day, million totally. We are giving for now. We already said that we have given 64 lakhs per dose per day and all at some point recently. So we are definitely catching up to the pace of vaccine, but we know that we have more than 18 years. The adult population is around 950 or 900 to 950 million people. Around that is the figure that is projected, which means twice that we have to cover roughly 1800 or 1800 or 1900 total doses will have to be covered by December 31st if you want to finish off this vaccination. If you want to target that, we should be delivering around 9 million, 8.84 million or 80 lakh. We said that we are currently delivering around 50 to 60 lakh per day, but we should be giving around 8 lakh or 8 to 9 lakhs per day. 80 lakhs, 80 to 90 lakhs per day or 8 million. Okay. So that is what we have at days where we have administered around 64 lakh doses. And in June, July, actually, we have increased the pace of vaccine administration has definitely increased. And if the vaccination continues at the same pace, we will be around 720 million doses short by the end. But then if we catch up on the pace, probably we may end up with vaccinating our adults. So the pace that is required, we just discussed. So we will need 300 million doses per month. So per day, if you require 8 means into 30, you require 240. So roughly, if you think of 9 million doses, you will require 300 million doses per month. So if we look at the slide that we previously saw, the Serum Institute of India has a capacity of 120 million, roughly 100 million. And you have Bharat Biotech, which is slightly lagging behind, but then they say they can up to 100 million, they can also produce. Plus, if you bring in the Sputnik also, we start manufacturing that also and bring in certain, the import of vaccine also, probably we should reach that target of 300 million doses per month. And then by then we would cover the adults. What about the children? So what is the status in India? We know that Covaxin has it started the trial for children in India in the 2 to 18-year-old age group in 3 groups, that is 2 to 6 years, 6 to 12 years, and 12 to 18 years old. And we are waiting for the results. But then there is also this question of should we vaccinate the children? Madam was talking in terms of vaccine equity. Across the globe, we are coming to that topic. We have people who have no access to this vaccine, including healthcare workers who are the most vulnerable population. So then the children, vaccinating children, do we need to vaccinate all children? We have pediatricians also amongst us who would tell us more on that. Generally, the infection is mild. So, but the long-term consequences of the illness of COVID is what wants us to giving the vaccine for children. Another thing is the children are the most affected in this outbreak. They are all indoors, and the long-term consequences of them being indoors, and those things we need to think of. We're all waiting for the vaccines for children. And vaccination of one way out, maybe that we do look out initially, at least we should vaccinate the children with comorbidities and those who live with high-risk population. Then another challenge we said is, or the way forward we said with regard to increasing the coverage is to increase the private sector participation. What is the situation now? If you look at the sites that are giving vaccination in India, they're around 92.3% is being given in government sites. Only 7.7% is being given by private sites. So should the scenario change? We know that the more than 60% of the healthcare is being delivered in India by the private sector. So why can't we mobilize the private sector more? They are now, some of them are purchasing the vaccines, but can we improve the participation of the private sector in order to improve the coverage is the question. What about Kerala? This is the statistics from the yesterday. We have 1,147 sites which administered the vaccine, and daily this keeps changing, but roughly it becomes around 1,200 sites delivering the vaccine, of which only 20% vaccination centers are in the private sector. Another point to note that is the number of centers. We look, this is around 3 months back. Let's say 3 months or 4 months back, 4 months back. Okay, so 4 months back, if you see that the number of private participation was 358. Probably earlier we were giving vaccines to the private sector, but now they are purchasing it from the manufacturers. But whatever it is, this has come down if you look at this figure. So should we think of making the private partners or private sector, we should make them responsible for delivering the vaccine. So another challenge. So we were talking so far of what is the vaccination coverage in India and Kerala, and we were trying to look at some of the perspectives or some of the ways out in improving the coverage. Now we come to another challenge. Madam has already mentioned is vaccine equity, equitable access to vaccines. We know that no one is safe unless everyone is safe. It's like poverty anywhere is a threat to prosperity everywhere. But then poverty and prosperity, I think we need to think of, it may affect us long term, but then this is there with us immediately here. The virus knows no borders. So no one is safe unless everyone is safe. So we need to think of the vaccine equity. We need to think of the other counterparts, our people in the entire globe, and this is something like vaccine apathy. If you can look into the global figures, 30% have received 1 dose and 15% have received 2 doses of vaccine, but only 1% in the low-income countries have received at least 1 dose. Only 1% have received at least 1 dose, which is which is disheartening to see. And so the overall picture may be rosy, but are the vulnerable yet continuing to be more vulnerable? And we know that COVID-19 situation has made those vulnerable people more vulnerable in terms of economy and so many things. And this is just the same, or rather it is bad with regard to the vaccine also. So this is the inequity state. The high income countries, 1 in 2 people get the vaccine, whereas low-income countries from the WHO say it's only 1.36 or 1 in 74 people get the vaccine. So this is one way forward, that is with the WHO, the COVAX, that is led by Gavi, the Vaccine Alliance, the Coalition of Epidemic Preparedness Innovation, CEPI, and WHO, and it aims to accelerate the development and manufacture of vaccines, They pool the risks, and they pool the funds, they forecast the demand, they get commitment from the manufacturers, get commitment from countries across the globe in order to meet the needs of especially the high-risk populations. And we should be proud that India has donated 198 lakh doses to COVAX. But then unfortunately, we came up with the second wave, and then we had to halt the supply to the COVAX, which actually we left them actually in trouble, because we had committed to give them more doses of the vaccine. But then we should look forward more towards that also. This is one picture which COVAX roll out in, I'm sorry for that spelling mistake, that's roll out in Sri Lanka. And it's a very neighboring country. Perhaps India could donate also, but then they had to go on with other countries donating. So with regard to vaccine equity in Kerala, we do have an initiative, that is the WAVE, that is Work Along for Vaccine Equity. Earlier, we had just pointed out that when we say there is a coverage of, to say for Kerala, we have 43% coverage, when you think of the total population, and that is receive at least one dose. But what is those people who are digitally back off? Are they who are the people who have received the vaccine? So in order to counter that, actually the objective of the campaign is registration of marginalized population, including those below poverty line and people residing in the remote areas who have no access to digital devices. So that's a ward level initiative. The ASHA worker is supposed to ensure that these people are able to register the co-vaccine. So that is actually a good initiative to ensure vaccine equity in Kerala. Another point that I would like to say is our PC sir was telling in the beginning that healthcare workers have been vaccinated. We have 135 million healthcare workers around the globe. And if this is a systematic review, shows that vaccine acceptance varied widely across the globe among healthcare workers, 27.7 to 77.3. That's showing that there is some form of vaccine hesitance. What does the ICMR Zero survey tell us? 85% of healthcare workers have antibodies against COVID-19, SARS-CoV, but 1/10 of healthcare workers were unimmunized. So what is the reason for this 1/10 being unimmunized? If you take in terms of the numbers, that will come to a little high numbers, 1/10 of the healthcare workers in India. So do we need to think of them? These are the most vulnerable people, or if we think of the changing behavior of them in terms of vaccine, if there is some hesitancy, we really don't know. It is another area of research by this percent of population, because healthcare workers was the group that was targeted early on. Is it that because they see that they have, some of them have got the disease and we don't know what such things. And then there are some studies in Nigeria which say that among healthcare workers also regarding the safety of vaccine, the efficacy of vaccine, there are doubts. And some of them say that they don't have time to take out to go for the vaccine. So these are some of the issues. So I think we need to have some look into this. And if you look at the healthcare workers in Kerala, this is the table from the vaccine bulletin, daily vaccine bulletin. Here also we see that 83%, only 83% have received 2 doses of vaccine. But luckily 100% of them have received 1 dose. So which means that there is not much they should be receiving. But this figure is not changing. I think for the past few days, it's 83%. So that also we have nearly 20% of healthcare workers partly immunized. So with regard to, so we have dealt regarding few things regarding the vaccine coverage, and we looked at vaccine equity issues and regarding the vaccination coverage of healthcare workers. Now with regard to the vaccine efficacy, all of us are aware of the vaccine efficacy of different vaccines, but I just want to bring one point. I don't know whether it should be explained, but when we say that a particular vaccine, so for example, if we think of Covishield, we have 70% vaccine efficacy. What we generally tend to think is that 30%, you give the vaccine to 100%, 30% would get sick, or the 70% will not get COVID-19. That is the outcome measure being the symptomatic COVID. So, but then that is not the case. It is a relative risk reduction, which is being mentioned, and relative risk reduction should be seen in the background risk of being ill with COVID. For example, if you have a background risk of symptomatic COVID is you have 10%. This is just a hypothetical figure that I'm putting. Unvaccinated, if you have 100 will get symptomatic, if you symptomatic COVID out of 1,000, it's really not 100 that we say, and vaccinated 30 will get symptomatic. This is when your background rate is 10%. So depending on the background rate, we do need to think of the vaccine efficacy. So in terms of vaccine efficacy, some points that just struck me, I'm just putting forward. So this is the study that is by the Covishield vaccine, that is not the AstraZeneca, actually that's the same. And they had done a study in UK and Brazil, and they have given into a group, they have given low dose followed by standard dose and standard dose regime. So 2 standard doses, when they gave the vaccine efficacy was 62%. And when they gave the low dose followed by standard dose, the vaccine efficacy was 90%. So 62% and 90%. So overall, they said the vaccine efficacy is 70%. So, but then when you look into the figure, you look into this table where it shows the age group that was analyzed with the low dose and followed by the standard dose. The low dose followed by the standard dose, 90% efficacy. You don't find people in the above 55 age group. You don't find people there above 55. So definitely we would expect that the vaccine efficacy would be higher there. So then we could think, and we are talking about overall efficacy of 70%. So if you look closely into some of these vaccine efficacies, the other studies also say that, like in another study on biotech, that is the response was weaker in participants 65 to 85 years old. So do we need to think of the solution or what the way forward is? Do we need to explore those elevations in the vaccination in elderly? So in this particular study, they looked at the geometric mean titers. In above 65, it is much lesser than that in the 18 to 55 age group. So this elderly, the vaccine efficacy in specific groups like the elderly, we need to look into. This is also other studies where they say that in the older age group, the immunity developed or the antibody response was weaker. So what I'd say to start off with, if we would analyze the breakthrough infections that we are getting. For example, in Kollam, if we looked at some, that's a very small figure, but then if you look at the breakthrough infections, those who died in ICU above 60 years, those who are vaccinated. So what is the vaccine efficacy in this elder? There was only one person in a small number of people when we just looked. There was one person, 51-year-old, others were above 60 years old. So vaccine efficacy in elderly specifically, do we need to look into? Another thing is diabetic. We know we have a lot of diabetic people in India, and Kerala is supposed to be the diabetic capital. So in the terms, and we know that the difficulty, Suma Madam and all those treating physicians are here with us, and we know how difficult it is to manage diabetes. Not we, I think they know how difficult it is to manage a diabetic patient with COVID-19 to bring the glycemic control and things like that. So we look at the vaccine efficacy in diabetes. The studies that are conducted, the Moderna and some of these vaccines, they had representation of diabetic participants in the trial. But then in India, we having Covishield and Covishield and Covaxin, we don't have data on the number of diabetic participants in these trials. So even if we do not have specific data on that, maybe at least we can look at the vaccine effectiveness study in elderly, in diabetics, and to start off with, let's analyze those breakthrough infections to see whether this being an elderly or being diabetic is a determinant of breakthrough infection, or we can look into vaccine effectiveness studies. And WHO has got a beautiful protocol which tells us how to do the vaccine effectiveness studies and by the different designs, including the ones that Indu Madam has mentioned in the beginning of the presentation. And efficacy against variants. This is also something that we need to explore. I'm not talking too much about it. We have heard a lot of it yesterday. So we need clinical trials. Some of them are coming up to see into the effectiveness or efficacy of vaccines against the mutant variants. Now, next challenge. So we talked about coverage, we talked about vaccine equity, we talked about vaccine efficacy, and we talked about why we need to look into some of specific groups like elderly, diabetic, and I didn't mention immunocompromised people. They form a small minority when we look at the whole population, but they are definitely a very vulnerable group. And for them, what is the vaccine effectiveness? At least if we don't have data with vaccine efficacy, can we go in for vaccine effectiveness studies? Now, next question is how long the immunity lasts. All of us know that natural infection, we said, would last, the immunity would last around 6 to 8 years. And this is one study which says that it will last around 1 year, around a year, even if you have had a mild infection. And it's come up in Nature, and compared with unvaccinated people, those who have received at least one dose had higher plasma anti-RBD. That is after the infection. If you have received one dose of vaccine, they had higher plasma anti-RBD antibodies of 50 and 50-fold increase in neutralizing activity. And we have mentioned earlier that we need to think of a policy change of whether there are no recommendations yet, but we need to think of whether we need to administer only one dose for those who have been infected or having deceased. So similarly, we would have the vaccine immunity also. That was what regard to the infection. So with regard to the vaccines also, it should not be very different. So we have studies from Pfizer and BioNTech which confirm that immunity is still lasting when you have it's still strong, 91.3% effective 6 months after the second dose. Similarly, evidence from Moderna that and we need to see how long it lasts in the days to come. And that there are studies which says after that the antibody levels wane off, but definitely we would have the cell-mediated immunity that would help us. But in case we have immunity only for a year or so, then we need to think of the boosters. And we need to give yearly boosters, maybe seasonal modification of annual vaccines to arrest the transmission of previous strains that may be considered. And the question is, will the economy be able to sustain such an effort? So how much of effort we are putting in, the entire health system, government health system, the JPHNs, those who have been behind the RCH program and communicable disease control are behind this vaccination program. Will we be able to sustain such a vaccination program for the years to come? This is a question that needs discussion. And then when we think about boosters, there is one thing that I came across, that is the mRNA vaccine formulation that would be ideally suited for repeated doses of the vaccine, as different mRNAs containing mutants. They can be rapidly synthesized and included within the lipid nanoparticle carrier, in contrast to the adenoviruses and the vector vaccines, because the vector vaccine formulation generates specific immunity which can limit efficacy of repeated boosters owing to immune-mediated clearance of the vector. So when you're giving repeated doses, we don't have the mRNA vaccines here. We were talking about thinking of importing vaccine, but then we know regarding the storage of the vaccine and all. But this is one thing that I came across. So I'm just sharing that with you. And we need to think of alterations in the delivery route and formulation. Like we are giving intramuscularly. Can we think of intranasal delivery? Okay. So another thing is change of formulation. So what is said, this tissue resident memory cells that are established in the lung, the initial infection, they are retained as non-circulating population that mediate the protective response in situ upon viral re-challenge. So this tissue resident memory cells, they can be generated from site-specific vaccination. So intranasal, sir, you're not hearing? Can you hear?
Yeah, we can hear you.
Okay, so the tissue resident memory cells can be generated from site-specific vaccination. And if you give that as intranasal delivery of mRNA vaccine, can promote this development of this tissue resident cells in the lungs. And the development of self-replicating mRNA vaccine, that is the change in formulation that they are proposing. That is, we are having non-replicating mRNA vaccines now, but if you have self-replicating mRNA vaccines, that may also enhance the T cell immunity set. So we need to think of such alterations in formulation and alteration in the delivery pathway. So protection against infection. So we know that we are all talking about when most of the initial studies on vaccine efficacy, the outcome measure was symptomatic COVID, prevention of deaths, prevention of hospitalizations. But we know that the prevention of infection, that's also important in arresting the transmission of the disease. How do these vaccines fare? So here we need to think of, I think Suma Madam put it in our group once, regarding intranasal vaccines. So if we look at intramuscular and intranasal vaccines, the intranasal vaccines, they are able to produce IgA, which you don't have being produced when you deliver the vaccine intramuscularly. Along with the IgG, IgA is also being produced. Also, the resident memory, we talked about resident memory T cells, but resident memory B cells are also, these two are being produced when you are giving an intranasal vaccine. So which means we are getting mucosal immunity, which is not obtained by the intramuscular vaccine. So perhaps that would help. So the shedding of the virus will also be lesser and the transmission also will be lesser. So that is the scope of this nasal vaccine. It provides us mucosal immunity, 2 additional layers of protection by the vaccine elicited IgA response and resident memory B and T cell response in the respiratory mucosa, which gives us an effective barrier to infection those sites. Also, intranasal the nasal vaccines give an earlier and quicker response than systemic memory cells. And it impedes the viral replication and reduces shedding. So these are the intranasal vaccines that are in clinical trials. So we have 3 live attenuated vaccines. We have protein subunit vaccine 1, and we have 3 vector vaccines. And we have luckily 1 nasal vaccine is in clinical trial in India by the Bharat Biotech. Again, that is a nasal vaccine, but that is not Bharat Biotech. It's not inactivated, but that is a vector vaccine. So that is also something that we can look forward to. So I think I've come to the end of my presentation. All we have tried to, what I have tried to put across is the coverages that we have in India and Kerala, the challenges that we are facing in to my limited understanding on what are some of the challenges and some of the ways forward to increase the coverage in terms of either scaling up production, in terms of mix and match of vaccines, in the change of policies, change of in terms of improving the private sector participation, the need for coverage evaluation studies. Then we looked into vaccine efficacy, and we looked at why we need vaccine effectiveness studies, especially in specific groups like the elderly, the diabetic, the immunocompromised. Then we looked at the immunity, the duration of immunity, and how we counter that with the boosters. We talked a little bit about vaccine equity, and I ended my talk with the intranasal vaccine. So people around the world are counting on us to do what is right and smart at this pivotal moment, and history will judge us harshly if we fail. And there is this responsibility on our shoulders, but let us all work together as a global community. And I congratulate our VC and team from the Kerala University of Health Sciences for taking this in the positive direction, for trying to bring in collaboration from international experts. We need to collaborate, work together as a global community of healthcare workers to give our best. So thank you. That's all. Can I stop?
Yeah, thank you, Senior, for the wonderful talk. And history will not judge us harshly. History will say good words about us. That is what we are doing now. I'm very happy to inform you that Jennifer Housen, who was supposed to join, could not join, but instead of that, Dr. Shyamasundram Kuttilil, who is the Director of Division of Clinical Care and Research, Institute of Human Virology, Maryland University, Baltimore, has already joined. Welcome, Shyam. Thank you. Coming at a very short notice. And I'm so happy to have our Professor B. Iqbal, who is advising Government of Kerala as the chairman of advisory committee on COVID and former vice chancellor of Kerala University of Health Sciences. And of course, I have a long list to say about, but I will say my leader and mentor, Professor B. Iqbal is with us. So we are very happy now. And Shyam, would you like to say something? You start with, start the ball going, ball rolling.
Thank you, Dr. Mohan, and thank you for KUHS for organizing it. Because I was not in the beginning, I think it will be easier for us to go into questions about related to what the future strategies are. And I think I just was that the last presentation was excellent and it covered most of the topics of the challenges of vaccination in general. I think one of the issues that Jen Hassan unfortunately couldn't be here, was supposed to talk about is a mix and match study, which is an interesting concept that's been developed and is probably going to be widely used in the next coming year. And that's what's the case scenarios where you really have to mix and match. And there are 4 real issues we need to address. One is shortage of vaccine, and people may not have enough, the manufacturers may not be able to meet the demand. That's one case scenario. Second aspect is that vaccine and waning of immunity. Many of us are immunized almost 6-8 months ago. How long will it last is we don't know. We don't really have good correlates of immunity. That's second challenge we have. And the third challenge is the vector problem, adenovirus vector. Adenovirus vector, we only have 1 shot per serotype of the vector. So if you have Ad5 based vector, the next Ad5 based vaccine would not work quite well. And that's why Sputnik design was Ad26 followed by Ad5. So you have to use a different serotype. And this is going to be an ongoing challenge. So generally vaccinology community is concerned about using Ad5 based vector, large population based vaccination strategy. So that's also a concern because subsequent Ad5 based vector vaccines would not take very well because of your immunity against adenovirus 5. So the last group, which was presented as a previous speaker presented, is the immunocompromised people. Those people may not respond the same way. And we just don't know because we don't know enough correlative immunity. That's where the mix and match studies work in. And the initial preliminary data showed that at least in the lab, really good response if you come with the CHAD2 vaccine, which is a AstraZeneca vaccine, and follow it up with an mRNA vaccine. So then you can really get the much booster T-cell antibody response. However, we don't know what we find in the lab is necessarily translated into patients, but that's the hope. Those studies are ongoing, and that's what mix and match studies would be a good option. That's probably how we vaccinate large number of patients in the next year or so.
Iqbal sir, please come. Sir, you're muted.
There are large number of issues that need to be addressed when you talk about achieving herd immunity by giving vaccination. That is the only option before us, apart from COVID control by non-pharmacological intervention. Now, Dr. Siniya has flagged off a large number of issues. One thing is that India has to get a large number of doses of new vaccines that are yet to be marketed in India. But there are 2 hurdles to getting vaccines from some of the very reputed companies like Moderna, Johnson & Johnson, Pfizer, etc. That have been circumvented. That is, there are 2 issues. One is indemnity protection clause, and second one was bridging trial clause. Bridging trial clause is the local safety and immunogenicity study. These 2 have been waived, and therefore there is no problem with regards to these 2 objections which these companies were raising early. So we do not make this as a condition for marketing these drugs, vaccines in India. Now we know that Johnson & Johnson have been given permission, Moderna has been given permission. It may take some time for them to be marketed, but Sputnik is here, and the supply is starting a big manufacturing unit, maybe filling and finishing unit in Goa. Even Kerala government is negotiating with them. We may also start a filling and finishing unit for Sputnik. Now, as things stand, within 2 or 3 months, as I see it, the Indian market may be flooded with a large number of vaccines from various agencies. The problem is that we cannot wait till then. We have to vaccinate people now. Now there are two issues again was flagged off here with regards to private sectors supply of vaccines. Now the government of India had a policy of permitting them to use 25% of the vaccines that are manufactured in India. This is by way of, because government is getting at a very subsidized rate, and to compensate for that and also to get them some finances, they have permitted this. But the problem is that Dr. Sinihas said that 7% of the outlets are by the private sector. That is not the issue. Only 7% are supplied by them. That is a major issue. So from the expert committee, we have given a suggestion to the Kerala government that they should provide large number of outlets free of cost to the private sector, so that they can with their human resources can supply the vaccines. Say for example, if you look at Trivandrum, I have actually discussed with these private players. Say we have KIMS and we have NIMS and we have SP Fort, etc. People going there and to get vaccine may be difficult. Suppose we start a vaccination center in VJT Hall, for example, from by the private sector. So a large number of people may come and receive vaccines. And moreover, in Kerala, the very interesting thing is that I hope that Dr. Shyam may forgive me for focusing on Kerala. We have a large number of medium and small scale hospitals in Kerala. Most of them are getting closed down. So we have given a suggestion to the Kerala government that we can provide them with vaccines so much so that they can also start large number of vaccine centers, mostly in rural areas. So that can be covered, because most of the private sectors, hospitals or the vaccine centers are in the urban, in the cities. So that is another possibility we have here. Now there is yet another hurdle which has not been looked into. That is to say that Covishield will supply only to those who order for 6,000 doses at a time, and Covaxin 2,880 doses at a time. So some of even the big hospitals like NIMS, for example, because their clientele is very small, so they cannot purchase this much amount. So the Kerala government has now started a project the state government is purchasing these vaccines and supplying them to the small players. That we are doing now. So therefore, I think that either the national government should change their policy of reserving 25% of the vaccines to the private sector, or we have to increase their outlets. One suggestion we have given to the state government is that you should provide freely outlets so that they come with their human resources and start these things. Now, the yet another issue which I don't know whether it has been presented is, what is the percentage of the herd immunity that should be achieved by especially when Delta virus is very predominant. Of course, the very term herd immunity is a misnomer here. Ideally, in herd immunity, there should not be any infection. Now, here we get a breakthrough infection, we can get reinfection. So the very definitionally, it is very wrong to say that we are going to achieve herd immunity. But nevertheless, we are using it. This term is used. Now, it has been argued that since the Delta is a predominant virus variant in Kerala and many parts of the world, we may have to achieve as high as 85% herd immunity. Otherwise, we may not be able to control the infection. This is another thing. Now, yet another issue which we are facing is that, very interesting thing happening in Kerala is that even though the TPR rate is high, number of cases are still high, the hospital admission is not that much. Maybe there are two things that should be addressed. Maybe Dr. Shyam may highlight on these things. Either the Delta virus has got high infectivity and low virulence, or better that the new cases may be reinfection and breakthrough infection. We should get a disaggregated figure, then only we can have this. Because in reinfection, and reinfection means those who are had infections and then getting reinfected with the Delta virus, and breakthrough infection is those who have received a vaccination and then got infection. So in both these cases, maybe the infection may be very mild and should be negligible, and very few people die. Now, the another issue in the national perspective we have to ask for is that based upon the zero prevalence study of the ICMR, the national government should have a differential supply policy, because those states who have got very low zero prevalence, why is that Kerala has got very low prevalence? That is because we have a prevalence rate is only 42.7%. That means ours is a very highly vulnerable, a susceptible population is more in Kerala. Why? Because of our very effective COVID control measures in the first stage. Okay. And therefore, we should not be punished for that. So Kerala should get more vaccines. And because of these low zero prevalence rate, that we have to demand. And secondly, even within the Kerala, if you look at the various districts, then the state government should supply more vaccine to the districts where the zero prevalence is very low. We have started the zero prevalence study here. The results will be analyzed by the 3rd week of August. By that time, we can do that. Now, another issue that has been talked about is the healthcare workers getting infected. That was expected. Actually, we expected breakthrough infection to happen in healthcare workers because they deal with patients directly. But then there is a problem, practical problem. Even when they are getting infected, especially medical students, Dr. Mohan may be worried about this issue. The students who got the vaccines are now getting breakthrough infections in hostels and all in large numbers. So what should we do? Now, the current practice is they still follow the same quarantine practices, 10 plus 7 days. Should we follow that? Should we follow in breakthrough infection? We should follow the 10 plus 7 formula. Can they undergo quarantine for 1 week and then resume their studies and practical work? This has to be discussed. And then it was also mentioned about the vaccine apartheid, inequality. In fact, Oxfam have come out with an excellent document, which is, and they call COVID virus a inequity virus. And they have extensively gone into details. And apart from vaccine apartheid, there is vaccine nationalism in various ways. One thing is that rich countries purchasing large quantities of, initially, even though the rich countries form only 14% of the world population, they purchased about 80% of the vaccine produced at that stage of time. So that is called a vaccine nationalism. But fortunately, as opposed to these two trends, there is a vaccine internationalism. And that is WHO COVAX movement is a vaccine internationalism. We have to call this vaccine internationalism. There is one another attempt that is being tried by Robert Gallo and others, he is also part of the open COVID movement. Because this is by way of cooperation and sharing, they try to develop COVID-related drugs, technologies, devices, etc. And one of their one of their attempt is to develop what is called open vax, a vaccine, a repurposing the existing vaccine to enhance innate immunity. It's a controversial issue. We had a discussion with them. They are trying to use vaccines like BCG, polio, MMR vaccines are being, in fact, Robert Gallo is taking MMR personally, thinking that it may increase the innate immunity. So they are trying that. Whether innate immunity can be sustained, all this can be debated. Nevertheless, there is this open one. Now, finally, see, deaths still happen. Now, we have to make a detailed analysis of deaths that are happening in our ICU unit. There are avoidable deaths and unavoidable deaths. And the unavoidable deaths means large number of this, especially in Kerala, elderly people with a lot of comorbidities. The disease itself can reduce immunity. See, many of the diseases, even diabetes can reduce immunity. That was presented here. Many cancers can reduce immunity. Many other treatments can reduce immunity. Even steroid is a sheet anchor in the management of many cancers. Even COVID, that itself can reduce. In transplant patients, they may be using immunosuppressants. So because of this reason, such deaths cannot be avoided. But are there avoidable deaths happening in our ICU? That can be due to one reason, maybe that we have yet to vaccinate the above 60 age group. Still, we have not completely covered them. In Kerala, 9 lakhs elderly are to be vaccinated. We are now trying to do a mopping up operation. And finally, regarding children, of course, there are different opinions. Pediatricians generally are of the view that children may not be affected. Affected in the sense they may get infected, but it will be a mild infection. We know that ACE2 inhibitors, ACE2 receptors are very few in them, and therefore very unlikely to be get infected. But nevertheless, what we are afraid is the post-COVID issue, like multi-system inflammatory syndrome in children, as even in adults, we can get them. So what we have suggested is that this happens very late. So if you suspect then you will have to do an antibody study in children who come to the hospital. And that facility is available. ELISA test kits are available. You may have to provide some chemicals. And then if you, the prudent approach would be that instead of talking a lot about children getting infected, let us try to manage this multi-system inflammatory syndrome. If you suspect such cases, you can do antibody studies. And if antibodies are detected, then you have to be very cautious. These are some of the things which came to my mind when hearing this. Thank you very much.
Thank you, sir. Thank you so much. Now, Dr. Indu, please take over. You are the moderator. Suddenly, I became a moderator in between.
Thank you. Thank you, sir. Senior had an outstanding presentation covering a range of areas, starting from the immunogenicity to equity, to the newer vaccines, to the coverage, to children, newer strategies, boosters, and all. Thank you, Dr. Shyam Kotlel, for your remarks. There are questions in the chat box. Shall we spend 1 minute to discuss that ICU issue raised by Iqbal, sir? I think Dr. Anil Satyadas is also there. Shall we get a remark from Dr. Anil regarding that ICU pattern? And Iqbal, sir, actually, when we were looking at the data in ICU, you must be aware of that. The number of people who are who have received 2 doses among those who are admitted in the ICUs. If Dr. Binu from Trishur is there, he can also respond. He is the PITSL coordinator there. So it is just like 1 out of 300, 2 out of 300, or 4 out of nearly 300 per month. While today I was going through the Trivandrum data when I went to the Trivandrum department also. The number, if we compare that to the pattern in the non-COVID ICUs, where the indication for admission are different, there the vaccination, the proportion is higher. So definitely vaccines are making the difference in Kerala, sir. Of course.
The point is vaccine makes the difference, but we used to make a very general statement that the infection will be mild and there will not be any death. But there can be death.
Yes, sir. But exactly. The number is much less.
In an unavoidable cases.
Yes. Out of the several hundreds.
Otherwise, what happens is one case will be reported in big headlines in the paper. So this has to be very clear. And apart from what you said, 1 in 300, 1 in 2, absolute numbers. When you look at absolute number from some districts, say 8 persons, 10 persons are dying in this unit.
Yes, sir.
Now received vaccine.
Yes, sir. Dr. Anil Satyadas, will you respond to Iqbal's point? Anil I can see Anil. Will you unmute? Probably he's not able to unmute. I'm sorry, I forgot that. Mr. Harilal, will you be able to unmute Dr. Anil, or we'll proceed with the questions in the chat box?
Madam, I have asked Dr. Anil to unmute. It's Anil Satyadas, no?
Yes, Dr. Anil Satyadas. Okay.
Dr. Anil, you can unmute.
Dr. Anil, will you unmute and speak? Okay. He's in charge of the critical care ICU unit and the multidisciplinary ICU unit in Medical College Trivandrum. Okay, we'll proceed, I think. Shall we move to the chat box? Dr. Shyam had many had congratulated senior. Do we call mix and match? I think there are a few questions prior to that. We talked about getting the private sector involved in the vaccination drive. We have hundreds or even thousands of slots that have been available. I think that is regarding the involvement of private sector, crowding and other issues. Some of these policy issues already Iqbal sir has addressed. And the upcoming policies and the involvement of more pharmaceutical companies in this. How safe is reopening of schools in Kerala with none of the children being vaccinated? Dr. Shyam, I think in US, children above 12 years are being given the Pfizer vaccine, but we are ready to, come down to below 18. I think Asin has already mentioned that we are expecting the Indian trials to be completed within a month or so and have a policy on that. And there is also availability issues, some of the equity issues. Like, with the available vaccines, whom will you vaccinate more? Those who have a higher risk. That's why we started off with the more vulnerable, the elderly and all. That was. Would Iqbal sir like to respond to? It's a policy issue also, sir. Opening of schools.
We have to examine it a little more in detail. I cannot immediately respond to that, but we have to live with the virus, and as a matter of policy, we have to live with the virus. Vaccination is going on. Vaccination below 18 years may come very soon. So I am hopeful that by early next year we may be able to open. I am not sure whether we can do it immediately.
Purushothaman sir also, I think in some of his talks, will you unmute Purushothaman sir? He's also showing his hand.
Purushothaman, you
He's
can.
professor of pediatrics from Medical College, Thrissur.
I have a difference of opinion about the two things. Immunization of children below 20. I have a different opinion. If there is a chance of immunizing below 20, it should be restricted only for the susceptible population. Why? Because we consider the number of kids less than 20 will be 90 lakhs. And when we consider any vaccine, the relevance of the vaccine, is it relevant? How much is this particular corona relevant, causing death or morbidity? 95% of them are asymptomatic, and the ICU admission is 1 in 2,000. Death is less than 1 per 10,000. And an entity, a problem, which is producing only that magnitude on one side. The other side is the safety issue. Unlike a person who is above 60, where the mortality is high, we have to give vaccine. Their years of living may be 10 or 20 years. But for kids, they have got another 70 or 80 years to live. So for that situation, a third phase trial is not enough. We should be ensuring safety much more. And regarding the vaccines available now, in India, this Covishield is there, mRNA is there, and in many of the European countries, this Covishield is not being licensed below certain age group. Europe, many of the countries less than 60 not recommended. In UK, less than 40 not recommended. Younger people are more likely to have problems. So such a vaccine should we give without establishing the safety? There is no hurry at all. I'm not against vaccinating, but we should be waiting for establishing safety. Post-marketing surveillance, the phase 3 trials should be waited for giving the vaccine to less than 20. But definitely vaccine should be given for a selected group of high risk. That will be whatever vaccine. In India, the vaccine in the third phase trial of vaccine is the Sidco vaccine will be coming by September. Bharat Biotech is trying, and their vaccination will be maximum by end of September, they'll be ready. So once it is ready, there will be a hue and cry for the vaccination. Actually, for schooling, starting the school, it's not at all needed, because all the COVID appropriate behavior is enough. And why we should be vaccinating a kid is to prevent infection to the adults. The adults are vaccinated, as Iqbal sir said, the 9 lakh people, if you cover within a matter of 1.5 months, the susceptible high risk population is vaccinated. And the number of kids who are likely to have problems of this, the severest of the situation, MISC, the number is too small, and very easily, if we educate, create awareness, that can be picked up and it's eminently treatable. So an entity where there is a treatable, there is a treatment. You can save if it is detected early. So what should be done is the awareness creation, pick them early, make measures to treat them, not immunizing everybody less than 20 with a situation when a situation of safety is not fully established. We should be waiting maybe for another year. I'm not for withholding the vaccination for the kid forever, but it's not the time to start vaccinating less than 20.
Thank you, sir. There's a question from.
What is the position in USA, Shyam, regarding what Dr. Purushothaman was saying?
Yeah, so one thing that COVID has taught us is that not to follow the American model, right? But having said that, US it's slightly different, right? Because it's not a resource issue. So that takes care of from a public health policy point of view. It's a regulatory issue. The United States Federal Food and Drug Administration has strict regulatory concern of using any agent, biological agents or vaccines or drugs in pediatric population unless safety and efficacy is established in that patient population. So they will not allow an EUA or an approval for that patient population unless safety has been demonstrated to the satisfaction of the regulatory agency. And that kind of regulatory challenge is not there in many other countries. That's why it becomes more of a gray area. So you cannot give vaccination to kids less than 12 because the vaccine safety is not established yet.
Thank you, Dr. Shyam. Dr. Altaf agrees to Dr. Purushothaman's position. Dr. Anish? Mr. Hadley, please unmute Dr. Anish P.S. Anish is an associate professor in College Trivandrum.
Yeah. Thank you, ma'am. I have got some difference of opinion to Dr. Purushothaman sir's view. I fully agree that the safety should be ensured. That is one thing. Second one is we need not wait for vaccination for the school opening. We can start school opening. But the vaccination of children are actually a concern for me. I will just try to explain. One is the seroprevalence data in Kerala is 44% compared to an Indian average that is 65%. If you just suppose in both Indian situation and in Kerala, it is 20% is because of vaccination. Then what does that mean? In Kerala, only 20 or 25% of seroconversion is because of the real infection. And in India, maybe 40 or 50% is because of the real infection. In pan-Indian situation, more than 50% of children has got antibody according to ICMR survey. But definitely, if you look at the antibody level in Kerala, that may be available in the next week. Definitely, that will be much less than that of an Indian situation. So whenever our children are going to go to their schools, they are more prone for large number of infections, or our schooling may be distorted because of the higher number of incidents of cases that may appear in Kerala. So we are, compared to any other part of India, we are trying to achieve something like a herd immunity through vaccination. But the real problem with vaccination is not going to give you a real herd immunity because the strain is Delta. That means the children should also be vaccinated to give some kind of an immunity. If the real Delta variant was transmitting, you can just avoid children and you can get, or you can use the other herd immunity, maybe a 60 or 70% of infections that can prevent infection in children also because of the background herd immunity. But we are not going to achieve that. We are going to achieve it through vaccination. Vaccination means definitely there will be breakthrough infections. That means the children are going to be affected. Through children, our adults are going to be affected. Some of them will be very much vulnerable. So if you want to protect our adult, definitely our children should get vaccinated. So that is my impression, or what I am actually thinking, that compared to any other part of India, in Kerala, vaccination among children is a priority. because we are going to achieve some kind of a herd immunity through vaccination. If you're just skipping less than 20-year age group, means you are avoiding more than 25% of our population from getting protected from the infection. Thank you.
Thank you, Anish. There is a question in relation to vaccines from Dr. Anthony. It's about comparing different states, like states like Karnataka, where the vaccination coverage is still high, continue to get cases, while states like Rajasthan, where the vaccination, Bihar, where the coverage is low, continue to. Would like, I think the seroprevalence survey, Iqbal sir has already mentioned about it. There, the seroprevalence is. Would Anish or Dr. Altaf would like to respond to it, or? Anish?
Yes, ma'am.
Yeah, this is regard a comparison of few states. Karnataka, where the coverage is high, but they continue. The vaccine coverage is high, but they continue to have cases. But in states like Bihar, where the coverage is low, they do not have many cases.
No, that is evident from the seroprevalence survey.
Yeah, I think that was already explained.
It is the real Delta infection may be much higher, kind of giving a herd immunity than vaccination. We cannot achieve that kind of a stoppage of infection by vaccination, because there will be breakthrough infection. So, a real Delta wave might have contributed much herd immunity in those areas, and they may be getting some kind of a fruit that they have suffered during the peak months of the second wave. It might have contributed large infections, hospitalization, deaths, and all. But now they are getting protected because of the herd immunity provided by rampant number of infections that happened at that point of time. Now, what we can do is we will go for vaccination, and we will try to reduce the severity of the infection by vaccination, even if we are allowing some kind of breakthroughs.
Thank you, Anish.
There is there is another very important reason also. It is our testing strategy, because our testing strategy, UN experts from outside Kerala, made the comment that out of 6 persons positive, we are picking up 1 person. Even the better performing Maharashtra is double, 12-1. Karnataka 18-1. But when it goes to states like Bihar, UP, more than 100 cases. They are picking
144, sir. 130, 1 out of 134,
exactly.
1 out of 100.
So therefore, the testing strategy and the testing methodology is also important.
Thank you, sir. Suma madam.
Thanks, Sindhu. This is not related to the school reopening. I wanted to say 2 points. One is I would like to congratulate Iqbal sir, because today I heard in the DDMA meeting that there is the state's recommendation is to complete vaccination of all those people above 60 years by 15th of this month. The reason behind it is that during the first wave as well as the second wave, the mortality were more in the people above age of 60 years. So I thought I think that's a very good recommendation, so that the elderly will get vaccinated, and when they get the next infection, maybe hospitalization and death will be lesser than what we see today. And now the second point is that I would like to Dr. Shyam to say about the waning of the immunity or the decaying of the immunity and the need for the booster vaccine. We know that it may come at a later stage as a policy, but how does it happen, and what are the other different studies show, and what is your take on that?
Sure. So the first point is that we don't really understand what correlates of protection is for COVID vaccine. So we are looking at, it's like blind people looking at elephant. We are looking at different things we can do. And that's what a lot these days, everything is published in big high-end journal, and that can really skew the field. We really don't understand what the case. And I tell you why this is, because even though we look at neutralizing antibody, the COVID vaccine does not behave like a neutralizing antibody vaccine, like hepatitis B or influenza vaccine. It is a disease modulating vaccine, right? So basically, when you get the disease, you're preventing infection, but you also ameliorating the disease that you get after you're vaccinated, that's definitely a T-cell mediated vaccination, right? There has to be an effect in cellular immunity that really interfering with how your capacity to live with an intracellular virus. So that means we are looking at neutralizing antibodies, and most of those studies saying that I don't have neutralizing antibodies titer is not 100% reliable. So the only way for us to look at vaccine and waning immunity is by looking at reinfection or breakthrough infection vaccinated people. And that's one of the concerning factors we have, is that we are seeing that in many parts. But one of the countries where we vaccinated a large number of people was Israel. Israel reported a lot of reinfection studies in the Pfizer mRNA vaccine, was basically all the new variant disease. When you have new variants that have two problems. Once, you could be vaccine or waning immunity, also non-protection of the immunity, because it could be completely escape the antibody responses or the T-cell immunity because the epitopes have changed. So there are two different issues come up. And now that Delta is a predominant reason, we really have to be concerned about that. And that's a general concern. As we see more and more infections on patients, people who are vaccinated, that really we've come to that stage that we need to really protect these people again. And the best way to do is booster vaccine. The contrary, so that makes perfect sense. So you can actually offer, the safety is already established, you can give another vaccine too. And that recommendation will very likely come in places like United States in the next month or so for the people who are more than 65 years old. And that's a done deal. Globally, that's a concern, because you actually, your priority is still to vaccinate unvaccinated immune people first. So WHO is really concerned about that. And that's one of the reasons they don't favor booster responses, controversy about it, because they really want people to get their first shot. First shot protects you a lot. Second shot protects you a lot more. And do that first before you get people start going in booster. And that creates a lot of confusion in an already confused field. And so that's where we are at this time. I think providing a booster at this time to susceptible population is a very, very easy decision for places where resources are not a concern.
I think Dr. Anthony
Indu, I want to ask one
Yes,
question to Dr. Shyam. Dr. Shyam, is there any study done on the cell-mediated immunity response to any of these vaccines?
Yeah, there are studies done at cell-mediated immunity, but it is unlike antibody titers. Cell-mediated immunity is not easy to quantify. That's been the major challenge. So people will have good antibody response, also have T-cell response, and then it complicates what kind of epitopes are you using. Do you really see that reproducible across the time? And it's not well standardized. The T-cell assays are not standardized like antibodies assays, where you can easily adapt. And I'm sure a lot of people in India are looking at serology. Even neutralizing antibody assays are complicated. Not all labs do it very well. And I give an example. For HIV infection, we have 40 years been working on. We don't have a consensus neutralizing antibody assay that everybody agrees on. So it is not easy. But these days, most of these things are not scrutinized because everything with COVID has happened so quickly. And so that's part of the concern, is that all these assays may be reporting certain things which may not be clinically relevant.
Thank you, Dr. Shyam. Some of those mix and match trials also have reported the cell-mediated immunity. May I now invite Dr. K. Shaji, the research dean of Kerala Health University.
I think we now know for sure that COVID is here for a long period. It will be there with us for a long period. And I think this is the right time to think about identifying cohorts which can be followed up over years. Mainly because one thing, we need to know more about post-COVID symptoms, syndromes, or outcomes for people who had one or more infections. To me, it looks as if it will be easier and feasible to have a cohort, statewide cohort of health workers as one group, with many reasons. One, they are at a higher risk for reinfection. They are a vaccinated group, and they are much more easily available for a longitudinal follow-up kind of study. So if all government and private institutions come together and recruit people who are willing to enter into a naturalistic follow-up study, then we will also know at a later stage that who is at a higher risk for getting infection. For example, are people who are junior residents and posted in the casualty who are vaccinated but are at a higher risk than people who are not that much exposed. And then we will also know much more reliably, because there, I think the health worker is likely to report things much better, even when that is a retrospective kind of report. We might then be able to gather a large number of people who can enter volunteer themselves to get recruited in these studies. And we are not offering any intervention. We are just going to study them, say, for 5 or 10 years from now. This is just my thought. I'm just sharing it with you. I think we need to, this will also serve a purpose of supporting and protecting this workforce, which we may need to be active and working for the public in the next 1 or 2 years. I'm just sharing my view on this.
Thank you very much, Sharisa. That's a wonderful way to conclude a webinar, which can spark off with a cohort. Actually, at the state, you have mentioned about a cohort of healthcare worker within the state. Actually, our Vice Chancellor is also the chairperson of the Association of State Health Universities in the country. So he can even plan one multi-center across the country. I think within the state definitely is under the purview of our university itself. Thank you very much, sir. Any more comments from Dr. Harikumar Nair, sir? He is the Dean, Faculty of Medicine. You are mute, sir.
You are not audible, Hari.
You are not audible. Hari sir, you are not audible. I think there is a problem with his audio. Our Pro-Vice Chancellor, Dr. C.P. Vijayan. Vijayan, sir.
Yes, when you were mentioning about the incidents which happened in Uttar Pradesh, that a nurse mistakenly administered 2 types of vaccine, I was thinking about errors in medicine, in inverted commas. Errors in medicine open up new windows in the scientific world. It is not for the first time that is happening. Several times in the history of medicine, it has happened. And another thing, yes, there was in the chat box also, it was mentioned, we are going to live with COVID for a long time, and whether the COVID vaccination will find a place in the universal immunization schedule. Yes, that is a question there. Yes, these are some of the thought processes I was having. Yes, lot of studies may require. And yes, our Iqbal sir mentioned about nationalism and internationalism and the different types of politics in COVID immunization. Yes, that is also we have to think about loudly, because in developed nations, 1 in 2 individuals are getting vaccinated, and in some of the countries, 1 in 74 is only getting vaccinated currently. Yes, these are some of the issues which should be addressed, and of course, research and the social activities should go hand in hand. Collaboration is required here also. Thank you. That's all.
Am I audible now?
Yes, yes.
Yeah, I don't have a comment, but I have a few questions to be asked to the audience or to the presenter. One is, why do we call the study of vaccines when you mix it as mix and match, when there is a real mismatch really happens? Is it because the immunity we presume to be a match in terms of immunity? That is one question. Can I ask the second question also now?
Yes, sir, together.
Yeah, the second one is as the question on the booster dose. I got two dose of vaccine, and after 2 months, I got breakthrough infection and relatively symptomatic. And can we call it as a technically or scientifically a booster dose in terms of COVID vaccination, or is it I should really get a booster dose if it is recommended? Can it be considered as a booster dose scientifically?
Dr. Shyam, would you like to?
So I'll take the mix and match. So yeah, the first question is why do you call it mix and match? Because in many places, like originally when they, like for example in US and Europe, you only give one shot, right? You have a Pfizer, you get the second shot as Pfizer. You don't get a different heterogeneous vaccine, even though they could cut similar. It doesn't, because we follow the phase 3 clinical trials that have been conducted for each particular vaccine. And some of these vaccines use different technology. One of them are mRNA-based vaccine, and the other ones are adenovirus vector-based vaccine. So they bring in different concepts to the table that you could match and get a better immunity. And it was discussed earlier today. Some of those papers, at least in vitro, shows that is beneficial. So that means if you give mRNA followed by another vaccine, you can get that. So that in principle, you are mix and matching different platforms of vaccinology. And that's why the terminology is there. I know that in some places you actually mixed match already. So that may not be less of a concern, but this is what the basis for using mix and match concern. The second question is that natural history is not similar to vaccine, because natural history means there are a lot of unknowns about how long natural immunity will protect you from vaccine. Those studies will take time for us to establish, because we don't really have very good correlates of protection and what kind of things we should look for in patients. So when you have a natural immunity, why we still recommend you vaccination is because we just don't know. When vaccine has been studied in clinical trials with the placebo, so you really understand what the effectiveness of a vaccination is. We don't have that kind of study with with the natural immunity. So it is difficult to rely on natural immunity, even though in principle you may be fine, it may be better than a booster, but scientifically, you really cannot equate natural immunity with vaccination. Vaccination is superior in understanding our protection because it was studied properly in large randomized controlled studies against a placebo.
Thank you, Dr. Shyam. I think, yes, madam, are you about to? Yes, madam.
Can I?
Yes, madam. Brief.
No, it's brief. In continuation to this, to Dr. Shyam, people talk about the hybrid immunity. Can you just elaborate upon that, or your views on that?
You mean the protection from
yeah,
one
vaccine
strain
followed by, yeah.
Vaccine followed. Yeah, so vaccine followed by infection. So
infection,
right. If you look at the initial vaccination for the 2-dose vaccination study, a lot of people got infected in the first 10 to 12 days, because the first 14 days you're not really protected. Because it's an active immunization, you do that. And if you look at the studies, the people, same number of patients got infected in the placebo versus arm. So that means there is no protection. After vaccination, you get infected, then that is really a breakthrough infection. Either you did not develop immunity, or you were unfortunately infected with a strain that didn't really confer protection to that. And once you get that in particular infection, what kind of immunity that you have compared to somebody who's to, we don't know that, but enough of that to make a recommendation in a public forum. Those studies have to be done into understanding how this is. We know from from our current understanding of medicine is that natural immunity survival is a very good immunity. You really, against virology, you really get protection quite a bit. But in the context of COVID, with all these new variants that come up, we really cannot guarantee that that really gives you protection for reinfection. One thing we can say that reinfection after a disease is much rarer than reinfection breakthrough infections for vaccine, which would somehow indicate that natural immunity protection is pretty good.
Thank you.
Dr. Shyam, I don't know whether it's a very crazy question. Can somebody be given 2 types of vaccines simultaneously? Does it give you extra protection or is it dangerous?
Yeah, it shouldn't give you, because it's still an active immunization. So you really need to space them out, your booster dosing, so that you can prime. It's a prime boost. It's usually what we call as prime boost strategy, right? You prime with something and then boost with something else. So that needs time for the immune system to learn. It doesn't really work rapid at one time. And that's why the spacing down of the two shots, vaccine strategy came around. So if you're giving the two at the same time, probably would not. I think this is a good question for you to talk to Dr. Gallo, who is going to come a couple of days from now. But one of the things that he's been looking at is these non-specific vaccinations like live vaccines. Can they boost vaccination for COVID or not? They usually lead to a lot of innate immune response, OPV, MMR, and BCG vaccination. If you combine that at the same time with the COVID vaccine, would you get a longer effect? It's a very interesting hypothesis, but not proven yet. And I'm sure he has a lot to say about that on Thursday.
Thank you.
Thank you, Dr. Shyam. Special thanks to you for joining this early morning. You can see the early morning sun in your room because you have saved us from in a crisis. Thank you very much. I thank our Honorable Vice Chancellor, Dr. Mohan Kunnumal, our Pro Vice Chancellor, all the speakers, Dr. Zinia, Dr. Shyam, and all those who have commented, Asma Madam, and all senior professors. Dr. Rajmohan sir is the head of School of Health Policy and Planning. Actually, the school is organizing this program. Rajmohan sir, I couldn't see you.
Oh, he's there. He is there. He is very much here. Dr. Rajmohan, maybe he can make a comment.
I don't want to make a.
Yeah. It is not the school of. Now the school is called School of Public Health.
Dr. Shyam, there are many trials of vaccines which has tested cellular immunity also. There are many. I can send you articles.
So yeah, let me clarify. It's not that I don't say nobody has tested cellular immunity. Cellular immunity is not quantifiable like antibody-mediated immunity, right?
Yeah, that is all true. But there are
trials
which have tested it, and I can send you that articles also. But few of them are from China. That is a problem.
It's not testing, Rob. Testing, you can look at T cell immunity, but it is not quantifiable. It changes from lab to lab.
They have their own, because the facilities are not that much. But still now, a good number of people are believing that cellular immunity is the villain. It is not nothing. Neutralizing antibodies has nothing to do with immunity. The picture has to be clear. We don't have a facility to measure this, because articles came in Nature and Cells are very much now uploading cellular immunity for protection. That may be one of the tests which is yet to come. Anyway, we have to see. Thank you very much for your tolerance. Indu can very well wind up the session. You don't need my help.
Mohan sir?
Yeah.
You are the leader.
Yeah. So thank you, Indu, for moderating the session extremely well. In between, I interfered, but you have done it wonderfully well. And I have a ton of thanks to Dr. Shyam Kudlil for helping us, coming suddenly in between his clinical rounds. Thank you, Shyam. Thank you so much. And thank you all. And we had a very good day. Thank you. Thank you.